if there's a, yeah.
Well, thank you very much, Johanna. Welcome everyone to this webinar. There were over 100 registrants on this topic. You can see how very, very important this is. And it's a great pleasure for FEAM to be working with EASAC. FEAM is the Federation of European Academies of Medicine. We have 23 academies incorporating veterinary science and pharmacy and pharmacology. We work with EASAC a great deal in terms of symposia and have very like-minded ideas. And this idea of decarbonisation and indeed the effect of the environment on health is one that's very close to the heart of FEAM and EASAC. And it's a great pleasure today that a colleague and friend of mine, Andy Haines, we are both in the same university, University of London, although different institutions, is going to speak on this topic. Andy, as you'll see, is an absolute international expert on the effects of the environment on health, and now vice versa, of course, as we'll hear some things today. This is going to be a really important and a really, really useful topic for us to look at and think about in the future. So welcome everyone. I'm delighted that this webinar has come to fruition, and I'll hand over to Volker Meulen from EASAC, who will welcome you also. Volker.
Okay, thank you, George. Like George Griffin, I also would like to welcome everybody and thanks for participation, in particular our speaker and panelists. And it's a great pleasure that we have this joint activity between FEAM, Federation of European Medical Academies, and EASAC. So let me give you some short introduction. What is EASAC? EASAC is the European Academy Science Advisory Council, and this represents all national science academy of the EU member states, plus Norway, Norway, Switzerland, and since January 1st, unfortunately, Great Britain, that they left us, but we are happy that Britain is still joining our activity. Yeah. What are we doing? We are giving science advice to policymakers, and we actually have 3 different areas. This is the areas of bioscience and health. That the other area is environment, and the third one is energy. And in these 3 big topics, we're giving science advice to the European Parliament and in particular to the European Commission. But we also are engaging with the Inter-Academy Partnership, which is a global network of science, medicine, and engineering academies. And EASAC, together with FEAM, have put up a number of topics which we have also then globalized. And the globalization is something which is of importance in these days. Not everything is centered about Europe, but we are all depending on global aspects. So what do we publish? We publish reports, we publish statements, we publish commentary, depending on the issue. And we are very happy that we could collaborate with FEAM on this issue, since we feel it is a very important document. And this document we will discuss today, and I'm looking very much forward to the discussion and see what our speakers, but also what our panelists have to say to this commentary and to the issue, of course, of decarbonization of the health sectors. So let's have a good discussion for the next 1.5 hours. Thank you.
Yes, thank you. And Andy has already been introduced, so we move on to the next point. And yes, Andy, you're already sharing your screen. The floor is yours.
Well, thank you very much. Thanks for the introduction and for asking me to give a brief outline today of the principles and value of decarbonising the healthcare sector. So I want to start with this slide, which is a simplified version really of a slide from Climate Action Tracker taken off the BBC website, but I think it very clearly outlines the scale of the challenge. So with current policies, we're heading for about 3 degrees warming or heating, I should say, by 2100. There's some uncertainties around that, but it's very far above the Paris target, which, as you'll recall, the Paris Agreement says that we should aim for well under 2 degrees and, if at all possible, 1.5 degrees. And you can see that we're well away from that. So we need to cut emissions by over 7% a year and keep on cutting at over 7% a year. Last year on a global scale, as a result of COVID, emissions did fall by 7%, but it shows us how not to decarbonize the economy, because it was accompanied by, of course, dramatic economic disruption, impacts on employment, economic and social well-being, mental and physical health. So it really underlines the need, I think, for planned but rapid decarbonisation if we're to keep, have any chance at all of keeping to the Paris Agreement. And remember that once we get over 2 degrees centigrade, the climatologists tell us that the chances of dangerous climate change are much increased, potential tipping points beyond which we cannot easily adapt are more likely to happen. So let me then say something about why the health sector is important. Well, thanks to our colleagues from Healthcare Without Harm.
Einer einziger Kandidatin von Frau Annemarie Keding. Punkt.
Have you been able to mute that mic, Johanna? Yeah, so thanks to colleagues from Healthcare Without Harm, they've shown us that if the global healthcare sector was a country, it would be the 5th largest emitter on the planet. So the healthcare sector is a major player. And I think we've just realized.
Ihre Nachricht an uns war allerdings wirklich sehr positiv gewesen. Punkt. Leider hat sie.
Sorry, I don't know where that noise is coming from, but somebody hasn't got their mic.
Dafür viel Druck bekommen, Punkt, und hat sich dann am Donnerstagnachmittag.
Is it possible, do you know where the noise is coming from, Johanna?
I'm trying to identify, but you go ahead, Andy.
Okay.
Well, sorry.
Yeah. So it's a major contribution to greenhouse gas emissions, and we know that there are different scopes of emissions. So there's the scope 1 emissions, that are the fossil fuels burnt directly on healthcare premises. There are those indirect emissions from electricity that are brought in to power healthcare facilities. But very importantly, there are these scope 3 indirect emissions. And we're now recognizing that these are the major emissions that contribute to climate change. These are the emissions from all the supply chains, from medical devices, from pharmaceuticals, transport, business travel, water, pumping water, and some of the very specific emissions that we get from the healthcare sectors, like, for example, asthma inhalers, anesthetic agents, and so on. Although anesthetic agents can maybe counted as scope 1 as well. So there's a whole range really of different contributing factors to the greenhouse gas emissions from the healthcare sector, and all of them need to be addressed if we're going to reduce the level of emissions to that that's required under the Paris Agreement. So we need to decarbonize the economy by 2050 at the latest, which really means making a lot of progress over the next couple of decades. And we've seen in the UK, for example, the National Health Service in England has committed to decarbonising even its indirect emissions by 2045. So this slide is a useful paper by Pickler and colleagues published a couple of years ago, which gives the healthcare carbon footprint of different healthcare systems around the world. So you can see that a number of countries like the Netherlands, Belgium, USA have high emissions as a percentage of their total carbon footprint. Some of the highest emitting nations emit almost, the healthcare system is responsible for almost 10% of emissions. And the average is somewhat over 5%. And if we look at the per capita emissions, they're also quite striking. You can see that a country like Luxembourg, small, of course, numbers, total numbers, but high per capita emissions. And you can also see the high per capita emissions from the US as well. So in some countries, over 1 ton per capita of emissions comes from the healthcare sector. So it really is a very substantial contributor overall. So where do these emissions come from? Here's the emissions from the National Health Service in England. You can see again the importance of medical equipment and supply chain. You can see how medicines and chemicals make important contributions, but there are also significant contributions from business travel, from anesthetic gases, and so on. And this on the right side shows you the activity type that's responsible. So for building energy, of course, much of the building energy is from the acute sector, from major tertiary care and secondary care hospitals, much less so in the primary care sector. But for medicines, the primary care sector is much more important because, of course, family doctors, GPs, primary care teams are prescribing a lot of the medicines that people use on an ongoing basis. So it's very important to understand where in the health system the emissions are coming from in order to devise effective strategies to reduce the emissions from these different scopes, scope 1, scope 2, and scope 3. To some extent, the healthcare emissions are related to the carbon footprint of the broader society, but they also reflect differences in the volume of pharmaceuticals prescribed and the carbon intensity of the health system, the extent to which it focuses on very energy-hungry tertiary care and correspondingly or alternatively on primary care. So this shows you how in the NHS, how there have been reductions in emissions over the years. And the striking thing about this slide is you can see that building energy has declined. So there has been overall about a 26% reduction in the emissions from the National Health Service over the years. And because of the volume, the increase in activity, there's actually a decrease of 64% in the emissions per inpatient finished admission episode. So you can see that there have been declines overall in NHS emissions. Most of those, of course, are due to reductions in building energy, seen on the bottom of the slide. And that reflects the gradual decarbonisation of the UK energy system. But when we look at the contributions of pharmaceuticals, medical equipment, business services, non-medical equipment and others, and procurement and so on, and visitor travel, you can see there's been much, much less progress, probably not much progress, and some have actually increased. So we can't just focus on reducing, on decarbonising building energy, although that's important. We also have to focus on these other emissions as well if we're going to be successful. It's also important to recognise that there are uncertainties, and there have been different estimates of the carbon emissions of the healthcare system, depending on the different methodologies used. They come up with slightly different percentages, but they're broadly in the same direction. And this slide just shows us where the uncertainties exist, particularly these purple colour here, where it's difficult to get reliable estimates of the carbon emissions associated, things like the end of life, how end of life products are, the end of life are treated, leased assets, employee commuting, purchased goods and services, and so and waste generated in the healthcare sector. So these are difficult to quantify, and we need to get better estimates of these. But there's still quite a lot that we can say about what needs to be done and where these emissions are coming from. So the next slide just shows us another important principle that we need to follow, and that is bringing the public with us. So the slide shows you the degree of public support for putting sustainability at the heart of the health system. It's a little bit out of date now, it's from 2015, but it shows you that even at that time, the majority of the public in the UK thought that it was important for the health care system to be sustainable. And a proportion of them felt, about a quarter, felt that sustainability should really be a top priority. I guess that proportion probably would have increased since then. That poll was done some time ago. It does suggest that there's a lot of support from the public for this kind of work. That support is probably increasing over time. We know from other opinion polls that the majority of the public, certainly in high-income nations, want to see governments as they emerge from COVID, emerging on a low carbon trajectory. There's also a lot of professional support. In the UK, over 90% of healthcare professionals in opinion polls support the leadership of the NHS in decarbonising the health service. Another important principle, of course, is making a financial case. Now, you can't always make a simple financial case because sometimes, because fossil fuel energy is in effect subsidised, we don't pay the full economic costs of fossil fuels, the cost of air pollution, cost of climate change. But in some cases, energy efficiency measures can result in savings. And this document from NHS England documents some of the energy efficiency, the savings from energy efficiency measures over the last decade or so. And the important thing about that was that the money could be kept in local health economies, so that the savings in energy bills were actually ploughed back into the healthcare system. The local healthcare system benefited directly from these savings. So certainly in terms of energy efficiency, that's possible to make that case. We're also seeing some technological breakthroughs, and we've seen this very much with COVID, of course. We've seen a lot more use of telemedicine, telehealth, remote consulting. And indeed, there is good evidence that telehealth can reduce carbon emissions. This is taken from a recent systematic review, and the slide shows you the carbon footprint against travel distance, the savings of telehealth interventions. So in the US, for example, where people may travel over 1,000 kilometers to a health facility, there are obviously potential very big savings, perhaps a third of a metric ton or more from telehealth. Obviously, in more densely populated areas, it's much smaller, around a few kilograms, but certainly if you add it up, it could be quite significant. But we have to be wary, I think, just blanket imposition of telehealth for all health problems. And this recent review or rather a survey of elderly people in the US expresses some of the concerns they had about telehealth visits. So there is some concern that the quality of care may not be as good. They don't feel as personally connected. Some of them have sensory impairments and have difficulty using the technology. So telehealth, telecare can be important, and it will be maintained, I think, to some degree in the post-COVID as we emerge from COVID. But there are concerns, and it's not suitable for all consultations, for example, where a physical exam is needed. But we do need to make use of technology as far as possible. And increasingly, health technology assessments need to include issues around sustainability. And there's a paper here by Marsh and colleagues making the case for expanding health technology assessments to include effects on the environment. So increasingly, greenhouse gas emissions and other environmental footprints should be and will be included in health technology assessments. And the paper on the left here maps out how greenhouse gas emissions are linked to care pathways, using the example of type 2 diabetes, the management care pathway, where there are opportunities to reduce the environmental footprint of these healthcare pathways. And increasingly, I think we'll see this mapped out for a range of different pathways. It's also important, an important principle is to identify win-wins. And there are big win-wins of decarbonising the healthcare sector. One, of course, is the reduction in air pollution. So as we reduce greenhouse gas emissions, we reduce air pollution. I had a graphic reminder of this the other day myself. I've got one of these home air pollution monitors here, and I had the monitor on, and I was in my working in my front room, and suddenly the air pollution level went up, and I was wondering, why has it gone up? The PM level's gone up to over 20. It was at 2 or 3, and I listened, and there was a motor going outside. I looked outside; it was an ambulance that had come to take a neighbour to hospital. So probably a big peak exposure was due to the emissions from the ambulance. And that's, I think, an important measure, an important lesson that we can benefit health by decarbonising the economy in the near term. And this is another example of a university hospital in the West Midlands in England, how they managed to raise public investment to put solar panels on the roof of the hospital. There was no capital cost to the health system. And some of the profits were ploughed back into making making energy access more affordable, tackling local food poverty. There's also increasing recognition that nature-based solutions are part of the solution to climate change. So if we support natural systems, they can help to lock in carbon. There's even plans for a National Health Service forest, which is so health professionals and patients and others are being involved in planting trees. And nature-based solutions can help us adapt to climate change, reducing flood risks, for example, reducing the urban heat island, as well as locking in carbon. And some hospitals, this is an example of a hospital in Liverpool, a children's hospital, where they've greened the car park. This was the car park here. And you can see the building has a green roof, so it has very low energy use. And when the children are in their hospital beds, they can look out of their window and they can see the green. And this was something that came out in the surveys when they designed this hospital. Children and their families said, we want to be able to go out and enjoy nature when we're feeling better, and when we're feeling sick, we want to be able to look out of the window and see the green space around us. So finally, a final, I think, principle and lesson is that we need to provide simple toolkits for people to help them understand what they can do in their own local setting. And this is one example of the Green Impact for Health toolkit from the Royal College of Family Doctors, the GPs. And they're encouraging local family doctor practices to use this Green Impact for Health scheme to guide their decarbonisation strategies. So it shows them where they can actually cut emissions for the maximum effect. So finally then, I suppose the final principle that I would allude to in this brief presentation is the importance of combining both mitigation and adaptation. So we have to adapt to climate change, because climate change is happening whether or not we like it. We are committed to a considerable amount of climate change. So we need to adapt to climate change. But at the same time, we need to cut emissions. So increasingly, we need to be thinking of integrating decarbonisation with adaptation and moving towards this concept of net zero resilient health systems. In other words, health systems that are able to withstand climate shocks, able to give early warning of extreme heat or disease outbreaks, but at the same time have a much lower environmental footprint than today. Remember, we need to decarbonise, we need to get to net zero carbon by mid-century at the very latest. And many countries, high-income countries with an important historical legacy of contributing to greenhouse gas emissions, need to decarbonise much more quickly than that. So I'll stop there. Thank you very much for giving me this opportunity, and I look forward to hearing the panel discussion.
Yes, thank you very much, Andy, for this presentation, which I think was giving a good foundation also for discussion later. I see there's already a question coming in, which we can address after the next presentation. But yes, again, if you have any questions, feel free to already write them in the Q&A now, or as you wish. So with that, we would like to move to our next presentation, which will be given by Robin Fears. Robin Fears is the EASAC Biosciences Program Director. Before joining EASAC in 2002, which is now already a few years back, he had many years of working experience in the pharmaceutical industry in the UK and research and development. And after that, he's also worked as an advisor to various bodies, including academies, universities, businesses, parliamentary groups, on issues relating to biomedical science and innovation within the European policy environment. And now, for many years, Robin has supported the EASAC work in the biosciences field, and he's also one of the main authors of this commentary. I will now share my screen. And give control to Robin so he can move the slides forward himself. Robin.
Thank you.
The floor is yours.
Thank you very much. And let me join in the thanks to all of you in the audience for participating with us today. You've already heard something from George and Volker about the interests of EASAC and FEAM, who collaborated in preparing a commentary that we'll be discussing from now. And Andy Haines has comprehensively introduced us to some of the objectives and opportunities for decarbonising the health sector, based particularly on experience in the UK, but more broadly. My task is to spend the next few minutes describing a little bit about what the academy networks in Europe have been doing. But I don't seem to be able to advance my screen.
Okay, if you try clicking on the arrows on the bottom right, does that work or not? Otherwise, I can do it for you. Ah, yeah.
Was that me or you?
I think it was you.
Okay, well, that's a chance to experiment a little bit more. Okay, so academies have a long history of interest. So can we go back one? How do I go? Hold on. Oh, yeah, okay. Right, so I think we are. Okay, so academies have a long history of interest in many of the issues for climate change, and amongst those, climate change and health. This is a report that was published by EASAC a couple of years ago. It was co-chaired by Andy and Volker, and covered a lot of the issues for the effects of climate on health in Europe, and thinking about solutions to those effects in terms both of mitigation and adaptation, as Andy finished by saying. In this particular report, we didn't discuss how decarbonisation in the health sector itself is part of the solution. That's our topic today. And EASAC with FEAM is extending a previous EASAC work to look at healthcare sector itself. Okay, so these are the objectives that we set ourselves when starting the work last year for commentary, essentially to raise the visibility throughout Europe for some of the opportunities for well-designed solutions of mitigation to help to decarbonise the health sector, but also to bring additional local and sometimes quite rapid benefits to the health of the population who are undergoing the mitigation. Drawing on the work of the UK and elsewhere that Andy's mentioned, we wanted to share and help others share some of the examples of good practice that are now being developed to stimulate equivalent actions elsewhere, and really to again raise the visibility of the health sector as a leader for tackling climate change more broadly, and in particular achieving the Paris Agreement goals. And one of the main points that I'll be making in the next few minutes, the sector can do a lot for itself, but there are also relevant European Union policies, and it's a great opportunity for us now to ensure that action in the sector can be aligned and can stimulate action at the policy level across Europe. Okay, you've already seen a very similar version of this slide from Andy. You could probably read his better than you could read this version, but essentially it reinforces the point that quite a high proportion of the carbon footprint of health services, at least in the UK, can be attributed to the supply chain, pharmaceuticals and other parts of the supply chain, followed by delivery of care itself. And as Andy emphasised, it's not realistic to try and decarbonise the health sector without attending to the supply chain and taking an integrated view of all the possible actions that can be taken forward together. This is a UK example, and I think the UK has taken something of a pioneering approach to setting ambitious targets for net zero, but surely many other countries will wish to follow similar strategies over the next few years. Okay, so in the European context, of course, that there may also be opportunities for concerted action among and between countries. Okay, this was a commentary published a couple of weeks ago. It's available on the EASAC and FEAM websites, and obviously there's a certain amount of detail in this that we don't have time to cover this afternoon. So I commend the publication to you for further information. Okay, interfered with my. For some reason, when you did that, Joanna, you interfered with my moving the slide. Okay. So, what do we actually do, and what have we written in the commentary? Well, here are some of the topics, and I'll come back to a couple of these very briefly. We try to take a broad perspective, and indeed you'll hear some more detail about some of these bullets in our panel discussion, which we tried to bring together to take perspectives on some of these key points for decarbonisation. In addition, I should just use this to advertise the point that EASAC has been active in other ways, more broadly in considering opportunities for decarbonisation. And my colleagues in the energy programme published a report a year or so ago on decarbonisation of transport, and they have another report coming out, I think next month or very soon, on decarbonisation of buildings. And clearly both those sectors are very important in considering change in the healthcare sector itself. And there'll be a lot more detail on some of the opportunities and challenges in Europe for decarbonisation in these other projects. I will now only provide one example, if I can move this slide, which if Andy didn't mention in any detail, so I'll just spend a couple of minutes on this. Essentially, if you look closely at the analysis in the NHS and so on, a significant amount of the carbon footprint in the supply chain for hospitals and other facilities is in food and catering. And broadly, I think it would be fair to say that in Europe, we are now part of a broader debate on sustainable food systems, that is modifying and developing our food systems more broadly to be more sustainable and at the same time to be healthier. And in terms of the objective, it says here to balance sustainability and of course nutrition in food systems, we have to take account of ways of reducing greenhouse gas emissions from food systems themselves, perhaps particularly in this context, agricultural, although there are many other aspects of the food value chain that lead to greenhouse gas emissions. So to reduce emissions from the food system at the same time as improving health. There's quite a large literature on this more generally, which don't have time to discuss, but essentially there are a number of examples of good practice being developed by hospitals to reduce the environmental footprint of their food supplies. And as I say, this is also an opportunity to improve the life of a patient and to improve the nutritional status. It's probably not a surprise to many of us that unfortunately hospital food sometimes leaves rather a lot to be desired. There's a long history of dietary advice being offered to catering services in hospitals, not always with very much success. But I think we do have an opportunity now to capture the momentum for sustainable, healthy diets, to look at the issues for decarbonising the food and catering in hospitals, and at the same time, of course, improving the diet of patients. And because this is a teachable moment, to instill longer term behavioural change when they leave hospital. There is an opportunity here to potentially to achieve a longer term behavioural change. And this is very relevant to a major EU strategy that many of you will know about, the so-called farm to fork strategy that is aiming to devise more sustainable food systems in Europe, less adverse environmental impact, more efficient and healthy production systems. And that's probably a discussion for another day, but certainly the potential role of the health sector in the farm to fork strategy, I don't think has been emphasised hitherto, but perhaps should receive more attention. Okay, so coming on to the broader issue, I tried to suggest, and Andy provided a lot of information on what the healthcare sector can do for itself to decarbonise and achieve health co-benefits. The question then is, well, is there something, or are there some things that the European institutions can do to help? And can the health sector align itself with some of the policy objectives and policy development that is already happening? Now, as many of you will know, much of health policy in the European Union is devolved to a country level responsibility. But there are also areas where the Commission and the Parliament have some responsibility, and of course there's much that they can do to support member states in their health policies. And I've listed a few of those here, that they're discussed in more detail in our commentary. For example, that the Commission is doing already quite a lot in setting standards for sustainable procurement. Probably that there's more that could be done, and there's more that can be done in a concerted way across all the member states to ensure consistency in sustainable procurement that will in turn apply to hospital facilities. Secondly, there are a number of elements in the supply chain, and Andy mentioned several of these, medical devices, pharmaceuticals, anesthetics, and so on. Pharmaceuticals are particularly important today, I think, for two reasons. One is they are actually quite a substantial element of the supply chain, embedded carbon. But secondly, we already have a European Commission pharmaceutical strategy underway that does emphasize the potential green credentials of pharmaceutical companies. And I think there's a lot that can be done to build on the Commission interest, and indeed the interests of pharmaceutical companies in helping to set ambitious targets for their own decarbonisation. Again, I think we'll come back to that in the panel discussion. Another area, I've mentioned farm to fork, that the renovation wave is a relatively recent policy initiative of the European Commission under the European Green Deal to improve the or to increase decarbonisation of a building stock. This is not just housing. Hospitals are exemplified as a significant pioneering, perhaps, part of a renovation wave. And in fact, quite a lot of Europe is in the process of a construction boom in hospitals. So this clearly provides another opportunity for embedding ambitious decarbonisation strategies. Probably the final point I'll make on this slide, in the interest of time, is digital health. And he mentioned telemedicine, and I think we will discuss this further in the panel. Again, the European Commission has a current digital health strategy, which it sees as very important in improving the life of patients, improving the delivery of health services, but there is no criterion in its digital health strategy for considering the implications for the carbon footprint of the services, and potentially that would repay further attention, particularly in the context of life cycle assessment. That there's a lot that needs to be done to account for the carbon embedded in new technology, as well as in the delivery of that technology. So my point is that there's a lot that the Commission is doing that is relevant to decarbonisation of the health sector, but it's not always recognised as part of those Commission activities. And I want to make one other point. Talked about carbon footprint of healthcare sector, but of course that can also be reduced in a different way, or an additional way, by improving population health and reducing the demand for hospital or other healthcare services. Clearly, the Commission is already, European institutions are already doing quite a lot to try and improve population health, strategies for air pollution and urban planning, and reduce smoking, and so on. Primary care in I think all of our countries has core roles in population health, not just in prescribing pharmaceuticals that Andy emphasised, but as gatekeepers and directing the secondary and tertiary care services, and in promoting and supporting healthy and sustainable citizen behaviours, with we hope a reduction in the burden of ill health. This all comes at an important time, because with the onset of the European Health Union earlier this year, many do discern a greater ambition for the EU in health. So quite possibly there are opportunities for a greater responsibility of the European institutions in some of the things we've been talking about for action in the healthcare sector. Let me finish with the last slide. Okay, so already a lot is being achieved by the health sector itself, and we'll talk more about that in the panel. If health professionals want to champion change, then they must lead by example. That is, attend to their own health sector. And of course, implicit in everything that we say, decarbonising the healthcare sector must not be at the expense of healthcare quality and equity. And indeed, some of the actions that we've talked about will improve quality and hopefully equity through the accumulation of local near-term health benefits. So finally, many of us think the EU can be more ambitious in policy terms in aspirations for health, and this is relevant to the subject we're talking about today. And finally, it's not just about Europe. There are opportunities here for the EU and member states to lead the wider international action on the targets for net zero in this area, for example, during the on fairly soon discussions in COP26. So I'll finish there, and thank you very much.
So thank you very much, Robin. I think we have a few questions that are coming through the Q&A, but I suggest that maybe we go through the panelists and then you can all see the questions. I have shared them with the speakers, and we will do our best to try to address those. Johanna, did you have something also for us before
yes, in addition to the questions that are already in the Q&A, I will post 2 more questions to the audience. And just to say, the attendees are also very welcome to comment on these. Yeah, so you're also able to comment, contribute to this discussion.
Okay, that's great. And I would just like to then go and present our great panel today. And the first person that will speak to us is Professor Maria Nilsson, and she's a professor at the Department of Epidemiology and Global Health at Umeå University in Sweden. So she's a professor in public health science, and her focus is on climate change and health. Her main interests are climate adaptation, public health interventions, health communication, and knowledge translation. Professor Nilsson co-leads the working group on adaptation planning and resilience for health in the Lancet Countdown, tracking progress on health and climate change. And she's also a chief editor of Global Health Action, which is a science journal with the publisher Taylor and Francis. She also was a member of the working group for EASAC in their report on climate change and health that was published in 2019. So I give you the floor.
Thank you so much for the introduction and for inviting me to join the panel. Decarbonisation of the health sector is an important topic, really, with so many perspectives, with mitigation in the core. And we should, of course, not turn a blind eye to the challenges, because there are many challenges. But at the same time, as we invest in building strategies and finding solutions, let us also stress the bonus effects for health from decarbonisation, and let it act as a driving force or a motivation for change, for transformation. My research is, as mentioned, climate change and health impacts. And over the last decade, science has built stronger on potential health gains and health gains from mitigation. And a green health sector means that, in addition to the fact that mitigation measures would also contribute to important emission reductions, it also have those positive bonus effects on health. if we choose to apply a green sustainability thinking to hospitals, primary healthcare, of course, also regarding, as mentioned, patient meals, transports, and new care models that also include well-developed digital health strategies. And also touching upon what Andy Haines and also Robin Fears mentioned, I would like to speak just a little bit about a study I was involved in on telemedicine. We performed a life cycle inventory to evaluate the carbon reduction potential of telemedicine activities and for a reduction in travel-related emissions. And I live in a county in northern Sweden where we have long distances. And this means that a patient in the northern part of the county would have maybe to travel 700 kilometers to go to the hospital and go back home. So of course, there is also an interest for that, providing good care. So it shouldn't only be seen as taking the patient away from the hospital. It actually may mean that you can have a meeting more often with the hospital when you don't have to travel. The study included Swedish data from rehabilitation units, and the carbon emissions generated during telemedicine appointments were compared with care's usual scenarios. Replacing physical visits with telemedicine appointments resulted in a significant 40 to 70 times decrease in carbon emissions. And according to the lower bound scenario in the study, telemedicine became a greener choice at a distance of only a few kilometers when the alternative was transport by car. And I've been working in Indonesia earlier, and also being stuck in a car in Indonesia, in Jakarta. You could really dream for distance care as well, I guess, because also traveling can be quite problematic also in those big megacities. Replacing those physical visits then, when in the study we concluded that telemedicine is an alternative, and it was concluded that it actually could contribute to a potent reduction strategy in the health sector. But to contribute significantly to climate change mitigation, telemedicine would be needed to be integrated also into ordinary care, healthcare activities, and not only considered to be a service to the few who lack access to care due to geography, location, or other constraints. But I'm quite sure that we could also, by acknowledging that not every person have access to this technology, we could also, of course, have the same kind of person-to-person visits as before for those. Talking about how climate change already impacts human health, there is plenty to be very concerned about. And I would like to see this as a big chance for our sectors, I mean, us working with health, to become more involved and play a key role also in motivating for solutions that over time may have actually global reach, at least wider reach and maybe global reach. Health professionals have important skills and are important role models. So when healthcare gets greener, that also means something. In many surveys, at least in high-income countries, trust in healthcare personnel has always been rather high, on top or close to the top. So we can say that what we do and say in the healthcare sector matters to many. Public health professionals have policy and advocacy skills to encourage organizational and societal change. And when having the knowledge, for me at least, it boils down to the action for decarbonisation also being about ethics. Our mission is to promote and protect health, and now being a part of the problem as a contributor to instead be a contributor to solve at least part of the climate crisis would be important. And we don't have to be pioneers, because we have pioneers. And Haines mentioned National Health Service in England. I think they can really be said to be a pioneer in this work. They started in 2008 to decarbonize, and now they've set strategies. They are quite impressive, I would say. So there are many good examples all over the world, and I'm sure that Scott Bradley from Healthcare Without Harm will also touch more upon this. The organization is really a strong actor when it comes to decarbonization, when it comes to policy making and so on. So I'm looking forward to hear what you have to say, Scott. Thank you.
So thanks so much, Professor Nilsson. And yeah, indeed, I should have said this, but I try to go very quickly to give you as much time as possible for all of you to talk and hopefully to address some questions at the end. But we have a really wonderful panel with many sectors represented here. So the next is Scott Brady, in fact, from the Healthcare Without Harm Europe. And it is, so Healthcare Without Harm in Europe is a non-for-profit network of European hospitals and healthcare providers, healthcare systems, local authorities, research and academic institutions, and environmental and health organizations. It currently has 151 members in 33 countries, which is quite impressive. And its mission is to transform the European healthcare sector so that it reduces its environmental footprint, becomes a community anchor for sustainability, and a leader in the global movement for environmental health and justice. So at Healthcare Without Harm Europe, Scott is responsible for the development and delivery of their climate smart healthcare program. So Scott, the floor is yours.
Great, thank you, Rosa. Thank you for the introduction and also for the invitation to come along today. It's great to see so many people dialed in for this webinar, and I think that's just a testament to the topic and the growing movement that's there. So yeah, I mean, I guess a few observations from my side. So the State of the Union address talks quite clearly about health crisis, and I think there's little doubt now that climate change is a health crisis, and we're seeing it more and more in the literature. We're seeing it more and more in the action, and it provides us with a really great opening to be able to get this message in. So it's great to see the commentary published recently, and it chimes with a lot of the work that we're doing at Healthcare Without Harm. And I think one of the things that I suppose that I would bring out here is that climate change is really a twofold issue for the healthcare sector. And we've seen this through the presentation. So we're talking about the healthcare sector as a contributor to climate change. So in the EU, it contributes around 4.7% of net emissions, which is a fairly significant chunk. But not only is it a contributor, it's also the frontline service for many of the impacts of climate change. So we're already seeing these impacts. We're already seeing kind of changes in disease vectors. We're seeing air quality impacting on people's respiratory health. And we're seeing more and more kind of severe events, heat waves and so on. So it's carrying a double burden, if you like, in terms of where it sits. And we've seen also that healthcare is highly dependent on other sectors. It relies on energy, it relies on equipment through its supply chain. So it's very much reliant on changes in decarbonisation elsewhere. However, I think what we've also seen is that it cannot solely rely on those changes. We can't solely rely on decarbonisation of grid electricity at a national level to allow us to reach zero emissions from energy, for example. And the recent work that Healthcare Without Harm has done in publishing its global roadmap for decarbonisation of healthcare has demonstrated just that. So it's shown that if we rely on the NDCs for the Paris Agreement solely, then we're not going to get there. There's got to be lots of other interventions that the healthcare sector itself puts in place to carry it towards net zero emissions. Of course, we need to also turn words into action. So we need to make things practical. We need to move out of the laboratory, if you like, and we need to move into the kind of real life world and actually start breaking that down and turning it into actual decarbonisation approaches. And the commentary is quite nice in the sense that it starts to do this. It starts to break down what we can do and how long it might take us to do it. So we can see the short-term actions, we can see some of the medium-term actions, and we can see some of those longer-term actions, such as system changes and so on. When we think around the kind of policy aspects of this, and particularly at the EU level, so Robin has already mentioned that policy is predominantly devolved when it comes to health and healthcare within Europe, but there are still things that we can do. I think we need to take a renewed focus on health itself, on public health, and not just on healthcare. I'm a carbon manager by background, so a bit of an analyst, and there's the old ethos that the emissions avoided is the best solution. So actually avoiding the patients coming into the hospitals in the first place by a focus on public health is some of the best solutions there, but also the most long-term solutions. Healthcare is dependent, however, on other European policies. So when we think of the Energy Efficiency Directive, we think of the Renewable Energy Directive, air quality, and there's other ones that are thrown in there as well. And I think there is a tendency, certainly from my experience, that healthcare can sit back and wait for changes to happen in these policy spheres. There's a nervousness, particularly from public hospitals, to get too involved in policy drive, if you like, or advocacy. And I think there's an opportunity there for the healthcare sector to take more of a leading role in that. And I guess that kind of brings me into my kind of final point, and it's around the power of the healthcare voice. So healthcare itself is around 10% of GDP in Europe, so it's got a significant buying power. But in terms of its institutional and its professional voice, it's fairly significant. People tend to listen to the healthcare sector, and they tend to listen to the health professionals as well. And if we also consider the care providers, the actual professionals that are providing care, their direct contact with patients, they have an opportunity not just to impact emissions in their own direct sector, but also in other sectors as well. So with promotion of active travel, for example, helps to avoid healthcare emissions, but it also helps to avoid emissions in transport more broadly. So there is a huge opportunity there. There's a huge power there that's ready and waiting to be harnessed, I think. And we are starting to see that now in our own organisation. There is a growing movement. We're seeing more and more hospitals coming to us, and we're seeing more and more healthcare professionals coming to us. And then I guess the final point I would like to kind of link back to here. So we're seeing lots of parallels with the current COVID crisis. I think one thing that COVID has done for our healthcare sector is it's highlighted where some of the issues are in terms of resilience, and where we maybe need to start plugging some of the gaps as well. And I think the other thing that it's demonstrated is how quickly we can make change when we have to. When the crisis is sitting right on top of us, we can adapt very quickly to that so that we can get it under control. And I think there's lots of lessons to be learned from that. So those are, I guess, my primary observations. So I think I'll hand it back to yourself. Thank you.
So thanks so much, Scott, for this. And it's a nice, let's say, transition into our next panelist, who is Pascal Garel. And he comes from an important sector. He's the chief executive at the European Hospital and Healthcare Federation, HOPE, which is an European non-for-profit organization representing national public and private hospital and healthcare associations, hospital, health, and social care service owners. So HOPE brings together 36 organizations from 27 member states of the European Union, plus the United Kingdom, Switzerland, and the Republic of Serbia. Its mission is to promote improvements in the health of citizens and a uniformly high standard of hospital care by the European Union, fostering efficiency, effectiveness, and humanity standards of hospital care by the European Union. So Pascal's main professional background is healthcare management, and he has over 10 years of experience in France into teaching hospital centers. Previously, he was also director of the European and International Department of the French Hospital Federation, and he also worked at the Central and Eastern Europe at the French Ministry of Health. So far, a lot of the speakers and previous panelists have addressed many issues of referring to hospitals, and Pascal is here also to bring us this particular view. So the floor is yours, Pascal.
Thanks a lot, Rosa. Thanks for the invitation. Congratulations for the major commentary by the academies. It's very important to see also that you guys are following the general trend on this issue. I will not try to defend hospitals, because we are covering more than hospital care, which was the original goal of organization at the beginning. But now we're covering more than hospital care. So we cover also primary care and, as you said, social care. Maybe to follow on what Scott just said, because it's nice that each of us follow on the other one. We are a very specific sector in the hospital and healthcare services by this way of functioning. And I really believe on bottom-up policies. And that's what we see with healthcare with ANR. I will give one example, and I will continue on that. But one example is the French Society of Anesthesiology, and those guys came with this fact that we know that more or less, and it was not clearly visible everywhere, but that operating theaters is 30 to 40% of waste of energy consumption and of purchasing in acute care hospitals, of course, not the social and long-term care. And there they took the initiative of accepting it and looking at it and see how we can do things. And there are plenty of good examples. And the point is that, as Scott said, and the others also showed, there are plenty of pilots and good practices and so on. So we need to move quickly, very, very quickly now. And it's not enough to have just individual examples, but it's still important to get the support of the professionals. Also, because we have been facing, and certainly we will in the future again, different logics in the healthcare sector. One is the culture of safety and single use. It's not so old, like 20, 30 years ago, we didn't have so much single use in hospitals. And the top of the top now was last year and now, this mask issue, the single-use mask issues. The good thing is now there are companies that are able to reprocess those so-called single mask issues. But my point is that safety has been driving policies of waste, huge waste. Nicely so, actually, because those waste, reorganizing waste, come from a very bad old fashion of throwing away dangerous waste on the fields. I just remember more than 30 years ago when I studied hospital management, the regional press in the western part of France where I was showing pictures of syringes in open waste fields. We've been far from this now. It's much better, but then it has produced much more dangerous waste, and the COVID was typically this period. So that's something important to remind. The second one is this pressure on finances also. The pressure on finances has led to try to get the cheapest. The cheapest means in many cases, again, the single use or so-called single use. And here we have a lot to go back from since I'm sure the pressure is going the same way as before. And we just back from this economic and financial crisis. So that's something that it's important. So we will have in this, and if we talk about EU, we will have those recovery plans, which will be adopted very soon. I mean, the member state has to propose them at the end of April. We'll see how far green they are and also how far they take into consideration the healthcare sector. And that's, for us, the most important element coming very soon. So again, there's different cultural approach needs also to be changed in our mindsets in the healthcare sector. And again, there are plenty of ways to reprocess so-called single use, and it's part of the supply chain carbon footprint, as it has been shown before. Another tension is, and I will take this simple example, is fluorinated F-gas, fluorinated gas, sorry for saying difficulty, which actually is more and more disappears from air conditioning, and hospitals, hotels, and cinemas were the main three consumers of those gases through the air conditioning. And in particular, if you consider adaptation needed, that means more air conditioning in the future. So F-gas progressively are disappearing, but we have this still big tension for one particular population, which is the asthma patients, who benefit from inhalator and would benefit also from some exemption at the moment. That is, we discussed with them and the European Commission recently and industry to identify ways to get rid of those inhaler with F-gas, but it's not that easy. That's not that quick as we expected from the industry. So that's why it's important all the players are around the table and play the same game. Again, the supply chain is the most important element here. We need the industry. So nicely today we have the pharma industry, but medical devices should also be with us. And I must say, in the past, there has been quite some tension about single-use or so-called single-use reprocessing of medical devices. And that's something on which we need to work, and we're pushing for this at European level. So I would like to finish also on saying that there are plenty of different levels. Of course, there's the EU level, as I mentioned, and as Robin mentioned also. National level, you spoke a lot about England, but there are also 3 other countries, nations, and they are doing things. But it's the same in the majority of European countries. Let's say the decision-making or even the financing is at regional level. So that's why it's important as healthcare with Adam, we also have members at regional level. It's also important to involve both people who are at local and regional level financing the care we deliver. And the same for hospital networks. There are several good initiatives. The French Hospital Federation has been pushing the government with 50 recommendation to help them green their hospitals. The same in different regions in Germany. North Rhine-Westphalia, for example, is one of them. So plenty of initiative also that has to be taken. So we started by healthcare professional. Yeah, it's good to involve them, but all levels should be part of this and coordinate with each other. With the huge complexity of the healthcare system we have in Europe, and 24 languages, 3 alphabets, and the difficulty to coordinate. We are not the US.
Okay, with that very complex landscape, I want to invite, last but not least, we do have in the panel Kirsty Reid, who is the Director of Science Policy at the European Federation of Pharmaceutical Industries and Associations, EFPIA, which represents the pharmaceutical industry operating in Europe. So through their direct membership, they have 36 national associations and 41 leading pharmaceutical companies, which amount to 1,900 EU companies that are involved in research, development, and manufacturing of new medical treatments. And so the FPI members have expressed their commitment to building a healthier and more environmentally sustainable future. So we're happy to hear today from Kirsty, who is responsible for innovation policy implementation. Her particular focus is on science and research matters. She also was involved in the Innovative Medicines Initiative, IMI, and she leads the work within FPIA on environment, health, safety, and sustainability, which is the reason why we, of course, are very pleased to have you. And then I hope we have some space for questions after Kirsty's intervention. Thank you.
Thank you, Rosa, and I'm very pleased to be here. Can you hear me? I'd like, first of all, thank you yourself at FEAM and also EASAC for inviting us to participate today on such a relevant policy and societal issue. As has been said, so I'm representing the pharmaceutical industry. That's within our companies and also the associations. We may be based in Europe, but our companies are very global, and it's important that the various initiatives that we take or undertake linking to sustainability are across the whole board, acting globally. Now, our industry sector is committed to making a positive impact on the lives of patients while operating sustainability, and we embrace the Commission's focus on the green agenda and the focus on becoming a more sustainable Europe. We recognize that something needs to be done. This has been highlighted in the previous presentations we've heard today, and we do this by, we need to reduce our environmental footprint as an important step as us as an industry to positively impact the human health. Now, meeting the commitments of the European Green Deal and the EU climate law, which is to target a 55% reduction of carbon dioxide emissions by 2030, is not going to be a simple task. And it will require collaborations, it will require innovation, and also it will create a new economic opportunities. Now, earlier, Andy, he referenced the three different sort of emission that are recorded within the EU, and it's important for us as an industry that we take responsibility for our carbon dioxide emissions in all of the inputs to our products. So not just the emissions for our operations, which we produce directly, and not just the emissions from the energy that we buy from our operations, but also the third emissions, which here is along our value chain, looking at the suppliers and also transportation, and looking at ways to reduce emissions from this. So it's not just, of course, the pharma industry, it's all sectors, industry sectors, which need to act responsibly for our decarbonisation. Now, with our FPA member companies, we've been working with them, and they're running a number of initiatives underway. But they're committed to establishing climate change policies and strategies across their entire value chains. They're also pursuing science-based carbon dioxide emission reduction targets. They're contributing to reduced energy consumption and increased energy efficiency, and are seeking opportunities to use energy from renewable resources throughout the value chain. Annually, and publicly, they're disclosing their carbon dioxide performance, calculated according to the recognized methodologies, like that of the World Resources Institute and Green Gas Protocol. Now, I noticed when you did your survey or question right at the beginning, there were at least a quarter of the participants online today are representing the industry. And if I was to ask many of them, they would probably be able to give some good sort of best practices which their companies are implementing to help decarbonize the value chain. And so we've been looking and working with our companies to sort of identify these best practices. Many of them are looking at how to reduce carbon emissions at their company sites. Some are switching to alternative energy sources. So some are using biofuel or wind farms, others are using deep geothermal energy as alternative sources. And there are also a number of initiatives which are underway to drive down the Scope 3 emissions, so along the value chain. And many companies have actually established strategies to become carbon neutral, either within the next decade or within the next 2 decades. It's also been alluded to quite often today, but not really called out, is not the climate change, but specifically circular economy. And the idea of circular economy is about becoming more circular, transforming or transitioning to a circular way, so there's no waste coming from either the manufacturing, research and development, or other aspects along the value chain. And the idea here is to keep to looking at limiting the global temperature increase to less than or equal to that of 1.5 degrees Celsius. And so our companies are actually implementing a lot of this along their value chain. They're looking at the product design, they're looking at the manufacturing and supply, they're looking at new business and models, and other new ways of turning waste into resources and prolonging life of products and changes to the consumer behavior as well, to help minimize the impact of the emissions and also on the carbon or climate change mitigation. Now, something that I was thinking when we were discussing today, the various aspects is, you know, the health sector is seen already as a high pollutant if we were to consider the whole value chain. And it's going to increase, I believe, in the coming years. We're going to be in the spotlight. And I see this mostly because, I mean, we're looking at vaccines manufacturing globally. We're talking about bringing in over 100, sometimes for some vaccines, 200 components, bringing them together and then manufacturing and distributing large quantities of vaccines around the world. This will show an increase in the health sector, but also, as has been mentioned just earlier, is the single waste use, the PPEs, that will also show a high impact in the coming future. So I think it's very good to sort of join forces in a way to find ways of decarbonizing our sector, to show that we are moving forward, because I do think that we're going to have a lot of eyes on us in the near future.
Thanks so much, Kirsty, and thanks everyone. I think we have really a few minutes, so if the audience is patient, we can maybe stay for 3 or 4 more minutes, but there were some interesting questions on the Q&A, and maybe I think Professor Haines, and do you want to address any of them? Most of them were clarifications about very complex issues.
Yeah, thanks. Well, very, very brief comments, and thanks for all the great comments by the panelists, with which I agree. First question was about medical devices and the approval process, and whether and to what extent sustainability or carbon emissions would be part of any approval process. I do think increasingly we're going to see procurement being conditional on suppliers decarbonising their own activities. So the timescale, of course, will vary according to different countries, but I do think that this increasingly is a direction of travel, I think. So that means that each manufacturer, whether it be medical device or pharma or other products, you know, will need to understand the carbon emissions from their own supply chains, and will need to look for kind of carbon hotspots. In other words, areas where there are particularly high emissions and where you could rapidly reduce emissions, whether that be through greater efficiency. I mean, in the pharma industry, I believe quite a lot of it's related to the kind of, sometimes it's the actual compounds that go into making the capsules rather than necessarily the actual pharmaceuticals themselves. So it may be the way in which these pharmaceuticals are packaged and so on, and are ingested, that may be up for changes. And I think, so increasingly, as Kirsty has said, you know, we're going to need to move towards zero carbon energy. We have to be careful about some of the potential zero carbon energy sources. Biofuels, for example, potentially are quite controversial. I mean, it depends what kind of biofuels you're using. If they compete with food production, then that's a problem, because that increases food prices and can have negative effects on health. So we need to use biofuels that don't compete with food if they are going to be used at all. And as much as we can go towards energy efficiency combined with renewables, with clean renewables. But I do see that as being a process for the future where increasingly procurement will be based on not just value for money, but also environmental footprint. The second point was about climate change adaptation. What's the difference between climate change adaptation for health and climate change adaptation for healthcare? Well, of course, some adaptation strategies not in the health sector have important implications for health. So if you protect floods, for example, nothing to do with the healthcare sector, but if you do protect people against floods through better flood defences, you can reduce exposure to floods which have negative effects on health. So both, we need to look at intersectoral adaptations that can benefit health, but also adaptations in the healthcare sector, like early warning systems, for example, for heat waves, for disease outbreaks would be one example of that, but there are many others. And then the final question was about nature-based solutions. And, you know, we could spend a long time on nature-based solutions. Sometimes I think they're used for kind of greenwashing purposes. So, but we shouldn't be thinking of them as alternatives to decarbonisation. We need to decarbonize and we need to use natural solutions where possible. There are 3 different types of nature-based solutions, at least: restoring nature, protecting and preserving nature, and innovative solutions like green roofs, for example. And they all have different pros and cons, and well-designed ones can benefit health. Badly designed ones could also have negative effects. You know, you can create biodiversity corridors, but if you get deer migrating along them that can carry Lyme disease, then that can have a negative effect. So it's like many things. You need to consider the positive effects for health and the negative effects, and make sure you optimize these kind of interventions. But overall, they can have big benefits for adaptation. So green space in cities can reduce the urban heat island effect, for example, but they can also have benefits for mitigation because they lock in carbon when they're well designed and so on. So it's a big and a very emerging area, and there's going to be a lot more to be said about nature-based solutions. I can imagine we could have a whole seminar on nature-based solutions.
Well, on that note, I think I would like to close because just not because I would like to close, but because we're running out of time. But hopefully this is the beginning and not the end of this discussion. And so please, if you have the contacts of the organizers, so send us your questions, and we will do our best also to follow up. And so for the final closing remarks, we have Professor Griffin from FEAM, and next Professor Volker Meulen from EASAC to give us some final remarks. George, sorry, you have to unmute yourself. I know that we were a lot of time with everyone muted, so no, yes. And maybe
I've got it.
Okay.
You hear me now? Good, thank you very much, Rosa. And thank you, Rosa and Johanna, for organizing this. Before I start, Andy has summarized beautifully where we've been, but there are 1 or 2 little points I'd like to bring up as well. Andy's first slides and the magnitude of the problem. When I saw the word gigatons, that my pulse rose. You know, we are not talking of small amounts. We are talking of huge amounts of CO2. And if we just forget particulate material for respiratory disease produced as part of this CO2 emission, we see what a huge problem this is. And the health sector, with 5% about of the being 5% emitter of the total is quite amazing. We've seen it's highly complex. There are many challenges and many interactions. Andy mentioned flooding. Well, who would have thought flooding is part of this? We haven't mentioned infection with vector-borne disease and the effect on vectors. There are many, many challenges which are interrelated here. So we have as scientists and deep thinkers to try and get all of these things together so we know just what we're talking about. So a scientific approach is very, very important. Now, in the healthcare sector and in healthcare, as we all are, it strikes me that we must take the lead in this. The energy sector per se, energy production, will think about it, but they may not take a lead. And we have to take a lead in terms of human health. Do no harm is a thing that Andy and I have taught medical students for years. We are now saying do no harm with energy. In fact, we should and must be on a downward trajectory in terms of CO2 production all the time. In the UK, Andy mentioned that it's going to be 20,045 before we achieve a reasonable level of CO2 production. That's 23 years from now. And to achieve the aims that we saw in Andy's first slide are going to be very, very difficult. So in summary, I think in the healthcare sector as professionals, we must take a lead. We must lead by example, and we must be ambitious. Public education is needed. And this is somewhere where we could actually have some effect, not by being dictatorial, of course, but by being sensible and explaining what the benefits are of simple steps to reduce CO2 production. And Scott's motto, healthcare without harm, is such a nice one to have at the back of our minds all the time. Do no harm, healthcare without harm. And we can do that through reducing CO2. So a great day. I've thoroughly enjoyed it. I've learned a lot and I'm going out invigorated. Thank you very much to all the speakers. I'll hand over now to Volker.
Well, thank you, George. I can support what you have said. I will not extend the discussion. I think what is important is we have to get going to discuss, and we have to bring the discussion into the hospital itself. To many hospitals, I'm sure there are countries where they have not even heard that this is an important contributor to CO2. And I would say our duties would be keep the discussion going and have more than this webinar we had today, but have other webinars to engage many other contributors to this issue. Thanks a lot. And it was worthwhile listening to all your contributions. Thank you.
And Andy, thank you very much for your talk. It set the scene perfectly for our discussion. Thank you.
Thanks so much, everyone, and have a nice rest of the afternoon. Thanks to all the attendees who were quite a lot, and we will follow up.
Okay, bye-bye, everyone.
Bye-bye.
Bye.
Bye.
Bye now.